Hi, my name is Arjuna Maharaj, and this is my presentation entitled Anticipating the Curve, Can Online Symptom-Based Data Reflect COVID-19 Case Activity in Ontario, Canada? Let's start with some background. So certain limitations exist on solely relying on laboratory testing alone for COVID-19 surveillance. Number one, there is a delay between transmission and test results. On an individual level, this can have certain implications, but on a population level, when we see daily reported cases, this often represents transmission from about 1 to 2 weeks ago. Next, testing is very resource dependent. The volume of tests changes greatly from day to day, and even month to month and week to week. The differing number of tests performed can make trends in COVID-19 over time difficult to interpret and predict. Enter syndromic surveillance and a subtype of syndromic surveillance called participatory surveillance. This allows individuals to self-report symptom data in real time, either through phone or internet-based applications. This crowdsourced symptom data can be used as a proxy for confirmed case counts. It can be used to help estimate the true burden of disease and can be used to forecast future epidemiological trends with strong spatial and temporal resolution. Up till now, there hasn't been any studies investigating the association between symptom-based data and actual laboratory confirmed COVID cases in Ontario. Therefore, the objective of this study was to determine whether self-reported COVID-19 symptoms can be used as a timely proxy for laboratory confirmed cases in Ontario. So how did we do this? Let's go over some methods. We use self-reported symptoms from the Outbreaks Near Me Participatory Surveillance tool. Outbreaks Near Me surveys volunteer respondents on a number of different parameters. This includes healthcare encounters, testing for COVID-19, and most importantly, if or if not they were receiving symptoms and what symptoms they were experiencing. We defined a COVID-like illness as the following: the presence of at least one of cough, shortness of breath, difficulty breathing, or a new olfactory or new taste disorder, or presence of at least two of fever, chills, rigors, myalgia, headache, or sore throat. For example, if a single respondent reported that he or she was experiencing fever and muscle pains or myalgias, this would be counted as a COVID-like illness. If someone was experiencing a cough, this would be counted as a COVID-like illness. We then tallied up the number of COVID-like illnesses per week and divided by our total responses per week and received a metric called CLI, percent CLI. We then compared weekly percent CLI, or the weekly proportion of those experiencing a COVID-like illness, to weekly case counts in Ontario and weekly percent positivity in Ontario. So let's go through some results. We received approximately 525 responses in Ontario from April 2020 to March 2021. After filtering out multiple responses from the same respondent each week, we were left with 297 unique responses each week from 67,000 unique respondents. We received an average of about 6,000 responses each week. If we look at some demographic data of our survey respondents, I'll turn your attention first to Figure A. Here we see the Ontario general population, and this is data from Stats Canada on a population estimate on July 1st, 2020. We see that there is a relatively a 50-50 split between proportion of males and females in Ontario. This was slightly different for our survey respondents. We see approximately 60% female and 40% male. And this was similar for those who received a COVID-19 test in Ontario, about a 60-40 split. This can reflect greater health-seeking behavior in females, or could also represent a greater proportion of females in healthcare. Next, let's look at the age demographics of Ontario. So let's start with the Ontario general population. We see those less than 19 in blue, those 20 to 39 in green, those 40 to 60 in purple, and those 60 plus in yellow. We see a relative even split between these four age groups. If we look at our survey respondents from outbreaks near me, we see that our survey respondents were enriched in those 40 to 60. And we saw a smaller proportion of those responding to our survey who were less than 19. Let's go over some of our trends over time. So I'll turn your attention to figure C. Let's start with weekly COVID cases in Ontario. So these are laboratory COVID cases, laboratory confirmed COVID cases in Ontario. And if we start in April 2020, we see a gradual decline in our weekly number of COVID cases as we were exiting the first wave. We see an all-time low of weekly COVID cases in Ontario into summer 2020. And we see a rise in COVID-19 into the fall of 2020. This peaked in January, and we see a fall into February. We saw a similar trend initially in the percent of survey respondents who were reporting a COVID-like illness. We saw a decrease into the summer. And in summer 2020, we saw a decoupling of the curve, the rapid rise in percent reporting CLI and a rapid fall. And this eventually gradually stabilized. We saw similar trends when comparing COVID-like illness from surveys to weekly percent positivity in Ontario. Percent positivity fell into the summer. It was an all-time low and started to rise into the second wave. We saw very close tracking between those reporting CLI from our survey to test positivity in Ontario into the summer. And we saw the same decoupling of the curves in September 2020. We hypothesized why this might have been occurring, why the curve started to decouple, and we turned to other seasonal respiratory viruses. So if you look at the figure here on the top right, this represents the test positivity of other common circulatory respiratory viruses in Ontario from Public Health Ontario. We see that other viruses are at very low test positivity, and this is likely due to pandemic mitigation efforts. We see very low amounts of adenovirus, influenza, and other coronaviruses. But we see quite the rapid rise of test positivity of enterovirus and rhinovirus. This rose in the fall, late summer and fall of 2020 and gradually declined. And this really did track well with our survey responses or percent reporting CLI. If we look at our correlations overall, we see that there is no correlation between weekly CLI and various metrics of COVID-19 in the province. However, if we look at our data before the spike in rhinovirus, we see strong positive and significant correlations between survey responses and weekly cases in Ontario, 1 week future weekly cases, percent positivity in Ontario, and 1 week future percent positivity. This may show a potential predictive power of syndromic surveillance in predicting future percent positivity in Ontario. Let's go through some discussion points. So overall, we didn't see any correlation between participatory surveillance and COVID-19 cases in Ontario or test positivity between our time frame of April 2020 to March 2021. There was a spike in rhino and enterovirus in the late summer of 2020, and this tended to track well with our survey responses. Other reasons why syndromic surveillance may not have tracked well with COVID-19 in Ontario could have been differing demographics, which our survey responses were enriched in those that were female and those in the middle age group. And another reason could have been other differing demographic factors, such as a higher socioeconomic status of our survey respondents, and those responding to survey could have been less likely to be racialized and experiencing homelessness. And we know that these are risks for COVID-19. Next, we saw a strong positive significant correlations between survey data and COVID-19 activity before the spike in rhinovirus. And we conclude that participatory surveillance may act as a proxy for COVID-19 in the absence of other circulatory respiratory viruses. Thank you very much.